So I just wanted to preface this presentation with the fact that One Health implementation and mobilization needs to happen at all levels. And regardless of whether we're talking at the community level or at the policy level, decisions at the higher level can really trickle down and have impacts at the local level. So this is a farmer that I met in my summer research this year in Rwanda. Her name's Mary, and like other farmers, she's dealing with issues of infectious disease, awareness, prevention, and control. And decisions made at the WHO and General Assembly meetings can really create a structural framework to do One Health implementation and help people like Mary at the community level. So the research objectives of my project were, one, to critique the current EID outbreak surveillance and response frameworks within the global health security agenda. The second was to analyze the challenges to One Health implementation at the WHO and evaluate existing entry points, and to provide recommendations for the WHO in mobilizing One Health frameworks to better anticipate and prevent disease outbreaks. So this is the current framework. It's reactive, it's response-oriented, it acts downstream, and it's unsustainable. So the GHSA has done an amazing job at enhancing capacity building across countries through country action packages, as well as joint external evaluations of health systems. We also have the International Health Regulations, the IHR, and like we learned this morning, it's a legally binding agreement that requires WHO member states to investigate and report infectious disease threats within 48 hours to the WHO. But that's difficult to implement because there's many disincentives to reporting an outbreak in your country, and there's also insufficient health systems capacity to determine when you actually have an outbreak of disease. So this framework really fails to utilize the preventive potential of other disease drivers, and it really places organizations downstream in where they're only able to implement response and not prevention. So this is why the world needs One Health. So One Health offers a preventive framework for monitoring and addressing EID threats before an outbreak even occurs. And in my opinion, at the very least, One Health could be used to identify priority areas at risk for outbreaks, and this could help to mobilize resources a lot faster in those situations and earlier. But there's a lot of barriers to One Health implementation at the WHO. So one, we're dealing with reactive investment frameworks and resource challenges. So we have a lot of vertical funding where funding likes to go to very specific, very narrow, very focused initiatives. And One Health is extremely broad. So how do you start shifting that funding to really be funding broad, multidisciplinary initiatives when we're really used to being very specific? It's also difficult to measure costs and benefits of prevention. So when you have an outbreak, you can measure cases and avoided human cases and do a cost-benefit analysis that way. But how do you know when you've actually even prevented an outbreak in the first place? So it's really hard to shift that to a preventive framework. We've also learned today that there's a lot of decentralization, fragmentation in One Health, and there's a lack of coordination, as well as performance evaluations for surveillance networks. As well as capacity challenges. There's a lack of veterinary capacity in many countries, and the focus on outbreak detections in humans alone delays the detection of zoonosis, and as we know, a lot of EIDs are of zoonotic origin. We also have institutional silos. So silos are equated with stability and control. This is our area of expertise. This is what we want to focus on. We're not really interested in going outside of that. And funding mechanisms also make allocation of financing across silos very competitive. So it's really difficult to spread that funding across silos to enhance multi-sectoral collaboration. Also, the issue of politics is always a big one. So political will is a huge issue in international organizations. The WHO and other organizations really like to promote this policy narrative of an outbreak. So an outbreak is a global problem. It can affect all different countries, and once we have an outbreak, we need to contain it. We need that containment narrative. And also principal agent problems. So how much authority do we want to give international organizations? How broad do we want to let their mandates be? And how much do we let them do before they're starting to infringe on country sovereignty? That's another issue. And as we learned in the previous presentation, there's a lacking environmental component of One Health. So far, there's a heavy focus on vector-borne disease and environmental quality, but there's a lot of existing entry points that are being that are going unused by numerous organizations. So here's some of my recommendations. So in terms of mobilization and funding, I suggest to create a proactive funding and resource mobilization framework. This could involve creating a multi-sectoral prevention fund for surveillance in the WHO. This could be placed in the WHO Health Emergencies Program or UN's emergency fund, or in some contingency fund in one of these international organizations. At the very least, we can start using surveillance data to identify priority risk areas to mobilize those resources sooner. Also, currently under the WHO and IHR mandates, countries are only allowed to donate funds to already existing health systems. Okay. And so we could try to shift more to prevention by helping build systems from the ground up. Also, to consolidate One Health development within the WHO to enhance its organizational leadership, One Health could definitely benefit from some centralization, as well as a pathways approach where we're not only talking about that outbreak narrative, but looking at outbreaks from a systematic perspective, where we're looking at impacts on development, impacts on financing, and the impacts of outbreaks before an outbreak has occurred, as well as very far after the outbreak, not just containment. For the ecosystem component, we need to continue to mainstream health within the Sustainable Development Goals, use multi-sectoral values to maximize co-benefits, and establish indirect policies for EID surveillance. So we could also recognize EID spillover protection as an ecosystem service, and we can monetize that within the UN's valuation of ecosystem services. Promise this is my last slide. So lastly, like meetings like this, we need to continue to engage stakeholders, work with the tripartite and UN Environment Program to really show different sectors and organizations their buy-in for One Health. What could they use One Health for? Because those conversations are still in silos. And last but not least, for cost and benefit analysis, we're still focusing on human infection alone. If we could start normalizing including livestock health and agricultural costs, we could really enhance the argument for the cost-benefit ratio of One Health. So that's it. Thank you for listening.